disorders. The abstracts and presentations are available on demand, but we have the presenters here for the Q&A session. They are Dr. Raul Martinez from the hospital in Spain. We have Dr. Tian-Wan Chang from Yonsei University in Korea, Dr. Ayesha Jamil, who is at Imperial College in London, and Dr. Francesco Sammartino, who's representing the Ohio State University Medical Center. And with that, I'm looking forward to a very informative session. And if there are any questions right now, if not, I will let Dr. Martinez, who's kindly here already, take the first question, which is in his paper where he successfully treated bilateral VIM. Actually, is Dr. Fernandez here? Do we have Dr. Fernandez?
I'm Martinez Fernandez. We have
okay.
two surnames, so it's
okay. Thank you. Well, I'll let you take the first question on safety and efficacy, and the issue of what do you think is in the source of the difficulties and adverse side effects in previous studies that have targeted open surgically the ventral intermediate nucleus of the thalamus?
Well, as you have mentioned, the available evidence show that there are a rate of side effects related to bilateral lesions, which is quite high, especially in terms of gait impairment and speech and dysarthria. Well, now we have a completely different approach with ultrasound. Consider that in the past, those lesions were made, or not as far away, but were made with radiofrequency. So you need to open the skull, you need to penetrate with electrodes towards the target. So, and you have a less controlled production of the lesion. So probably those lesions were more invasive than the lesions performed by ultrasound, and you have a worse control of the performing of the lesion. So now, probably the rate of side effect was more related to the invasivity of the whole procedure than to the lesion, to the bilateral lesion itself. According to our experience with ultrasound, the stage bilateral lesion is pretty well tolerated. We have had no significant permanent side effects. Patients, after the second side, they have a gait imbalance, transient gait imbalance, which is also a side effect of unilateral lesions. But after 1 month, 3 months, these side effects vanish. So I think that the difference between the approaches is the difference in the invasivity of the procedure. One is surgical, the other one is it's only lesional, a very focused lesion. So I think this is the main difference that allows us to do bilateral lesions without side effects right now.
Thank you.
Well, looks like we do have Dr. Ayesha Jamil with us. Can you hear us?
Hi, yes. Can you hear me?
Hi. While we fix technical issues with Dr. Chang, perhaps, Paul, do you want to go ahead with your questions for Dr. Jamil?
Yeah. Welcome, Dr. Jamil. The first question I have for you is your study, one of your studies that you presented, used the combination of Zona Incerta and VIM to get really excellent relief of tremor. It's just unusual to do a combination study. Did you have any previous experience in unilateral patients in lesioning ZI itself alone?
So our neurosurgeons who regularly perform DBS do have experience of ZI lesioning, but we haven't. This is the first time that we've been doing it with MR guided fixed ultrasound. And that combination was a discussion between the neuroradiologists, the neurosurgeons, and the neurologist who works very closely with the neurosurgeons. So that was a decision made based on previous DBS.
I also found this approach quite interesting, Dr. Jamil, and I say that because one thing that you do have with DBS is greater precision in terms of it is not a lesional procedure as opposed to focus ultrasound being lesional procedure. So you'll be below the coordinates of VIM. There are certain authors that have shown extension of lesions towards the brainstem or inferiorly could be associated with greater risk of side effects such as gait imbalance or speech difficulties. So that's why I'm interested in hearing your thoughts as to why you choose to additionally lesion ZI.
Yeah, no, I agree. I think this was something that had been considered. And actually, in our results, we did have some side effects that we believe were due to inferior lesioning below the ZI. And I think going forward, it is something that we need to consider. So yeah, that is definitely a concern.
And do you use direct imaging of zona incerta as well? There are certain imaging methods that can now directly image ZI, or do you still use stereotactic coordinates mostly?
So we are, up to now, we've been using stereotactic coordinates. Actually, unfortunately, our practice is on hold due to COVID. And in this interim, we're doing lots of sort of trials on healthy volunteers in terms of using tractography and trying to find better ways to target both the VIM and the ZI. So we are hoping to start before the end of the year, and that is something that we want to consider going forward.
Rahul, you want to go ahead? You had some question?
Yeah, thanks, Dr. Jamel, for your presentation. Very interesting. I want to ask you if you have tried this approach with Parkinson's disease patients, with Parkinsonian trauma. And the other question is, if you have done it, have you noticed any difference in akinesia or rigidity?
We haven't actually done that in a trial setting for Parkinson's disease, and I'm not personally aware of any private patients that we've done, but I think that is something that the team were looking towards doing, but we don't have any experience to present in terms of data. No.
Since we don't have anybody else joining here so far, I would like to ask a question from the panel. How many people here use diffusion tractography for lesioning using focus ultrasound?
We use it to analyze the effect on the tract after the lesion, but we have not used it yet for targeting. These are very pertinent because this is one of the methods that has been proposed for targeting. In our opinion, in the opinion of our team, the accuracy of DTI is still not as good enough to be considered for generalized targeting of the patient. So we think it's a very good technique to see the effect of the lesion in the tracts that are impacted on, but not yet for targeting. But it's very promising for the future, sure.
And what about you, Dr. Jamil?
Yeah, so this is what we are working towards incorporating regularly. But at present, we haven't done one with tractography, but that is our aim. So I was actually myself scanned on Thursday as a healthy volunteer to practice our DTIs, and we were able to get quite good targeting. But obviously, we have to translate that into practice on a real patient.
Yeah, just in the full disclosure, we use and have used diffusion tractography now for years, and we generally use DRT for our targeting, and we superimpose it to anatomical images, and our approach over the years has now moved from sort of starting at the level of VIM and generally actually now going a little bit higher to avoid adverse events of speech and dysarthria as well as ataxia. So that might be an approach that I'm hearing that a lot of people are starting to use. So I encourage you to perhaps try it out, or maybe not even use the information, but process the tracks and see how it correlates with your outcomes.
I totally agree.
Yeah,
We have
agree.
Dr. Chang back. Hi, Dr. Chang. Can you hear us?
Yeah, I can hear you.
Okay. So I'll ask you the same question I asked you before. For this project of yours, how did you use CT data? Did you use uncorrected or corrected CT data? And how did the CT data compare with autofocused MR data? Do you have any kind of comparative idea for us so we can evaluate one technique versus the other?
Yeah, so we evaluate the CT for every patient, and we compared the CT-based correction and the autofocus-based correction. So we made the score, which is the similarity score. It's a score between zero to 1. And the higher is the better, and the lower is the more unreliable one. So can I share my window?
I am not sure.
Yeah. Can you see?
Yes.
Can you see the table?
Yes.
Oh yeah. So you can see every patient in the 8 patients all examined the similarity scores. So we compared it with the CT and with the autofocusing technique. With the autofocusing technique, the similarity score is more higher than the CT-based one. So we compared it, and we thought that the autofocusing was a better method of correction.
Well, thank you for that. I do see that Dr. Sammartino made a comment on our group chat. So I just wanted to check, is Dr. Sammartino with us? So Francesco, we wanted to ask you, for your connectivity-based analysis, where were the controls coming from? And did you have any, if it was from the connectivity project or Connectome project, do you have any concerns that the techniques that you used and were used at other institutions could be different?
Yes, so what we did here at Ohio State, we used an approach that's been described before by Dr. Fox et al. It's called lesion network mapping. So we basically, as he has done in different disorders as well, he has started analyzing the lesions, and from the lesion came out on like several subjects to the areas that are preferentially connected to those boxes, and then identify basically shared pathways or areas, cortical areas and subcortical areas that are associated with those lesions. And so the rationale for doing that is that we don't have large enough data set of hundreds of subjects to test this hypothesis. So as he has done before, he has basically used publicly available data sets of normal controls and seeded the lesions from the patients in those data sets. And so all the lesions are actually coming from our center. It just they're basically projected on the human connector.
Okay, thank you.
Thank you. I'm afraid it looks like our time has ended. I want to thank all the presenters in spite of our audiovisual challenges, and also congratulate them on some major contributions to the field. Thank you.
Thank you so much.
Thank you.
Have a great day.
Okay.